we are already done with the outer and middle ear disorders. Now, your inner ear. So, let's first talk about the disorder listed there, your sensorineural hearing loss. Okay, so recall that there are two main types of hearing loss. So you have your conductive hearing loss and sensorineural hearing loss. Allow me to use this illustration to discuss further your sensorineural hearing loss. So when I talk about sensorineural hearing loss, it is any kind of hearing loss, any kind of disorder that could lead to the damage of either the cochlea or your auditory nerve or acoustic nerve or vestibulocochlear nerve. Basically, your cranial nerve number 8. Okay, so what are the risk factors? Genetics. There is genetic predisposition when it comes to hearing problems. Sex. Your sensorineural, your hearing loss, is more common in men among women, okay, compared to women. Then age, there is direct correlation, meaning hearing loss is higher as the person ages. So what are the possible causes for this? One, it could be noise-induced. When I talk about noise-induced hearing loss, there could be two reasons. Prolonged exposure to high noise levels or brief exposure to excessively loud or very loud noise. Okay? Now, this could temporarily or permanently damage the delicate structure of your organ of Corti. Other than that, class, take note of occupations such as your carpentry, your plumbing, and then your mining. So people who are exposed to this kind of occupation would have a tendency to have cumulative damage to the ears. Now, viral infection, mumps, measles, chickenpox, and your poliomyelitis could lead to your infections. This kind of infections could damage your inner ear. Other than that, you also have your torch infection. So recall when I talk about torch, this would include your toxoplasmosis, other infections, your rubella, your cytomegalovirus, and then even your herpes infection. Okay, then you also have your acoustic neuroma. So when I talk about acoustic neuroma, it's an intracranial tumor that would arise from the Schwann cells of our cranial nerve number 8. Okay, and this may cause unilateral sensorineural hearing loss. Okay, so take note, acoustic neuroma, it's unilateral. Then you have your ototoxic medications. So class, for your ototoxic medications, the particular classification there is your aminoglycosides. This class of medication, your aminoglycoside, that would include your gentamicin. And then other medications, for example, your loop diuretics, your acetyl salicylic acid. Then you have your chemotherapeutic medications, especially your vincristine and your cisplatin. Okay, they can all lead to ototoxicity. The thing with ototoxicity, class, is that if it is detected early, okay, and once the early signs and symptoms are diagnosed or found out, okay, once the drug is stopped, the damage tends to be reversible. Then you also have your Meniere's disease. So when I talk about Meniere's disease, it's a dysfunction of your labyrinth. Okay, we'll talk about that later on. But for now, just remember it is characterized by paroxysmal attack of severe vertigo and hearing loss. Paroxysmal meaning on and off. Presbycusis, the age-related hearing loss, and then you also have your trauma. By the way, for your presbycusis, you need to know that the factors associated with your presbycusis are as follows. 1, family history, then exposure to loud noise, and then smoking. Okay, so smoking has a very strong predisposition towards hearing loss. Okay, so all of these factors combined could lead to either external and middle ear damage. If it is external and middle ear damage, that would obviously lead to conductive hearing loss. But most of the factors listed above would lead to nerve damage. Damage to your acoustic nerve or your auditory nerve or our vestibulocochlear nerve. Okay, cranial nerve number 8 leading towards your sensorineural hearing loss. By the way, it's also wise for us to know, since you're learning also psych, okay, this is actually a type of conversion disorder. Okay, under your somatoform disorders, that a severe emotional reaction could also lead to psychogenic hearing loss. Okay, but since we're learning med-surg, you need to know that the physiologic causes of the hearing loss needs to be ruled out first before we consider the psychogenic hearing loss. So, what are the early signs and symptoms? You have your tinnitus, inability to hear when they are in a group, okay, the tendency for them to turn up the television. Okay, later on, there will be decrease in the quality of life, and then you will have safety problems. Other signs and symptoms, okay, that are discussed specifically in your textbook: speech deterioration. You also have your fatigue, indifference, social withdrawal, the tendency to separate themselves, okay, from other people. Insecurity, because they are not sure if they're hearing it right. Indecision and procrastination, okay, they are not knowing the deadlines because they were not able to hear about it. Okay, suspiciousness. Then there could be false pride, the tendency to become lonely, okay, and then the tendency to dominate the conversation. Okay, dominating the conversation is actually a coping mechanism for them to ensure that they understand the conversation, whereas their unconscious goal is actually for them to dominate the conversation so that they will not be lost track during the conversation. So, all of those factors combined, class, would lead to your sensory neural hearing loss. By the way, you need to note that to prevent your sensory neural hearing loss, or to detect, your sensory neural hearing loss or any type of hearing loss which is present at birth, we have your universal hearing screening. Okay, so class, we have your hearing screening test. Your hearing screening test is done among neonates, class, okay, before they are discharged from the hospital setting. That is already the mandate of the law. Okay, so now try to find out what law is it that mandates for your universal hearing screening. Okay, there are actually, again, two types of hearing loss, so conductive hearing loss and sensory neural hearing loss. To compare the two, okay, we need to know that in conductive hearing loss, there is better hearing through the bone. Okay, the patient has a tendency to speak softly, and then he would hear better in loud environment. Okay, and then the hearing aid can help. For your sensory neural hearing loss, remember the damage is already your cranial nerve number 8. Okay, due to the trauma to the noise, aging process, Meniere's, or ototoxicity. The main problem here is the ability to hear and process your sound. The sound would become muffled, and then hearing aids could make the sound louder, but it would not make it clearer. Okay, it's just amplifying the sound, but it can't aid the patient on the audibility or the clarity of the sound that would be interpreted in the inner ear. So, what do we do if there is hearing loss and we are dealing with this patient? Determine, of course, the best way to communicate. Okay, will it be writing, will it be gestures, or will it be sign language? That is, if they know your sign language. Then, look and listen to your patient. When talking to the person, face the person and do not cover the mouth. Okay, just reacting because right now in the time of pandemic, this seems to be difficult. Okay, but this could be done maybe using teleconferencing, wherein you are not covering your mouth when you are talking to the patient. And then speak slowly and distinctly. So the purpose, by the way, of not covering the mouth is to give your patient an opportunity to perform lip reading. Okay, usually class written communication is found to be an excellent resource. Okay, it's an excellent resource. Other than that, by the way, I would like to add that another cause of your sensory neural hearing loss is genetic problems. So among the genetic problems, you have your Waardenburg syndrome, you have your Usher syndrome, you also have your Pendred syndrome, and Jervell and Lange-Nielsen syndrome. If you would want to know about the differences on these syndromes, try to open up your textbook. Okay, so by the way, so going back, this is how you would manage a patient with hearing loss and communication. Okay, they might need hearing aids, especially conductive hearing loss. For sensory neural hearing loss, have them educated what's the purpose of using your hearing aid. Okay, telephone amplifiers may be needed or other assistive devices as available. And then the use of your sign language, your speech reading, lip reading, and then the use of your visual cues. Okay, these are all important to help your patient feel that they are not at lost when they are conversing, and that still conversation is still possible. Now, okay, so class, that's it for your hearing loss. I would like to add another topic, which is your motion sickness. Okay, your motion sickness is actually a problem related to our ear. Okay, so class, your motion sickness, etiology is constant motion. Okay, because motion sickness, as the term implies. Okay, the nausea and vomiting that your patient is experiencing is actually because of the overstimulation of the vestibule, which actually happens when we are traveling. Okay, so what are the signs and symptoms? Okay, if you're having motion sickness, I'm sure you can relate to this. You'll have sweating, pallor, nausea, and vomiting, again due to overstimulation of your vestibule. So what is our management for this patient? Okay, you take antihistamine. Okay, antihistamine, an example of which is your dimenhydrinate. And then you also have your meclizine. Plus your meclizine is your bonamine that we commonly heard of. Okay, so class, the purpose of your antihistamine here is to block the conduct of your vestibular pathway. Then we have your anticholinergics. An example of your anticholinergic is your scopolamine. Class, your scopolamine would have a side effect of dry mouth and drowsiness. Dry mouth, because recall, anticholinergic, you should have sympathetic related effects. So in that case, class, it will be your dry mouth. Okay, so just for you to have an idea of how is motion sickness related to our ear. Our education, class, for our patient is that they should be taking the medication at least 15 to 30 minutes before their travel. Okay, they don't expect the medication that by the time they'll take it, it will be effective right away. So it's not wise for them to take it when they're having their trip already, because they would have motion sickness while they are aboard or while they are on board. The next one, class, is your BPPV. So kindly take note of this, your BPPV. Class, your BPPV is your benign paroxysmal positional vertigo. A very common diagnosis also in the hospital setting, wherein the patient will have, okay, present in the ER with intolerable vertigo. Okay, so class, this is usually characterized by a brief incapacitating vertigo. Okay, nausea and vomiting, which is related actually to the position of the head. Okay, this is usually the affected ear was turned down. Now, what is the cause? The presence of debris in the semicircular canal. Okay, there are debris in the semicircular canal. What is our management? So we commonly use drugs. But another management is your canalith repositioning, or what they commonly refer to as your Iplay maneuver. Basically, the purpose of your Iplay maneuver is to allow for the dislodgement of the debris in such a way that it will be removed from the semicircular canals. Okay, in pharmacology, you'll be giving your meclizine and then your prochlorperazine. These medications are intended again to stop your vertigo. Okay, we'll talk about your Iplay maneuver. So class, this is how your Iplay maneuver is being done. So first, the patient is seated facing the examiner, and then the hands are stable supposedly if you're the examiner, and then you would move the patient rapidly to supine position with the head extending, okay, in this like manner. Okay, the head should be extending a little bit. Now, the examiner would move to the head of the table and then reposition hands as shown. And then the head is quickly rotated to the other side, okay, in this case to the left. Stopping with the right ear upward, and position is held for about 30 seconds. And then the patient rolls onto the left side while examiner rotates his head until nose is angled towards the floor. And this position again is held for 30 seconds. So let's look at this. This will be the movement from number 1 to number 5. Okay, assuming that there is debris present on the semicircular canal. And then the patient is rapidly lifted into sitting position. And then the entire sequence is repeated until no nystagmus can be elicited, okay, during the procedure. Okay, so basically the purpose is to dislodge or to remove the canalith or the debris from your semicircular canal. Okay, as a nurse, class, I'm not able to perform your Iplay maneuver. This is usually done by a physician. Now, okay, so that's for your benign paroxysmal positional vertigo. Okay, by the way, as the term implies, paroxysmal, so on and off, positional is related to position changes. Then we have your labyrinthitis. Okay, the next disorder there is labyrinthitis. Class, when I talk about labyrinthitis, it's basically inflammation of the inner ear, because another name of your inner ear is your labyrinth. Okay, it can be caused by bacteria or a virus, okay, producing a vertigo that would last for about 3 to 5 days. Class, if this is usually bacterial, that would originate usually from the otitis media as a complication of your otitis media. Okay, for the viral causes, then you have your URTI, your mumps, rubella, rubiola, influenza, and then your herpetiform disorders, okay, which could cause class inflammation to your inner ear. So what are the signs and symptoms that this patient would have? There would be sudden onset of incapacitating vertigo, which is worst on the first attack, lasting for 3 to 5 days. Imagine that, vertigo for 3 to 5 days. Then you have your nausea and vomiting. Then you have your tinnitus and then spontaneous nystagmus. If this condition, class, is not managed, your patient could have meningitis. So what is our advice for this patient? Class, the patient is advised to have complete bed rest. And when we say complete bed rest, the head is usually immobilized between pillows and the patient would be in a dark room, okay, to allow the patient some time to sleep. IV antibiotic therapy is given for this patient in the form of your ampicillin. Antiemetics to stop nausea and vomiting is given to the patient in the form of your chlorpromazine. Then class, your anti-vertigo such as your dimenhydramate is given to the patient also to address vertigo. Your gait and physical, okay, your gait training and physical therapy are done if there is persistent balance problems, even though the patient has already been treated with the prescribed medications. Okay, because if we will not be treating this, it may lead to meningitis. Meningitis, serious infection because it also already involves your brain structures. Okay, so that's it for your labyrinthitis. Now, let's go to your Meniere's disease. Class, your Meniere's disease is also known in other textbooks as your endolymphatic hydrops. Now, class, your Meniere's disease has two possible causes: overproduction of your endolymphatic fluid or decreased reabsorption of your endolymphatic fluid. The decrease on the reabsorption may lead to malabsorption or block in the endolymphatic sac. This block could lead to your endolymphatic hydrops. Okay, now, what are the signs and symptoms from this patient? Okay, class, there is decrease of hearing because of the dilation of your cochlear duct. Okay, there is vertigo because of the damage to the vestibule caused about by the compression of these fluids. Then you will have your sensorineural hearing loss. Okay, if you would look at these three here that are first listed, your vertigo, which is episodic. So take note, the vertigo here is not continuous, it's episodic but could last for 3 to 4 hours, including your tinnitus and your fluctuating sensorineural hearing loss. These are actually the classic signs of your Meniere's disease, or oftentimes referred to as the triad of symptoms for your Meniere's disease. So take note, class, that the sensorineural hearing loss for this kind of disorder is fluctuating. Other signs and symptoms, you'd have nausea, vomiting, sweating, giddiness, nystagmus, severe headache, loss of balance, the tendency, class, for them to fall on the affected side, which would lead to, or because of disequilibrium, okay, and class, disequilibrium sadly could awaken our patient at night. Okay, then you have your pressure and fullness in the ear. Now, on physical assessment, everything will be normal except for your cranial nerve number 8 assessment, because after all, our problem is on cranial nerve number 8. Okay, then Weber test. Your Weber test would of course show indications of sensorineural hearing loss. Okay, so you'd expect sound to be lateralized on, is it on the affected ear or the unaffected ear? Since this is sensorineural hearing loss, you'd expect it to be lateralized on the unaffected ear. Okay, then class, on audiogram, it would appear to have Pike's peak, and then the electronistamogram would be normal, or there could be decrease in your vestibular response. Okay, there could be decrease in your vestibular response. Now, what is our management for this patient? Class, for this patient to be managed, 1, limit salt intake. Remember, we're talking here about fluids. So remember that sodium goes with water. So we limit the salt intake of this patient. Okay, so canned food, frozen food, processed food need to be avoided. The patient must be maintained on low sodium diet, which is 1,000 to 1,500 milligrams per day. And this could already be found on the usual Filipino cuisine, class. Okay, no need for you to add table salt. That will already be enough. The usual salt content of the food that we usually take would already have enough of the sodium. Limit caffeine, because your caffeine, class, would have a diuretic effect. And in this case, we are giving diuretics also to your patient. Okay? Avoid monosodium glutamate, your bitsin. Avoid acetylsalicylic acid because it would manifest as tinnitus and dizziness whenever there is toxicity. Okay, so what is our medications for this patient? Antihistamine still using your meclizine. Tranquilizer if your patient is unable to sleep or anxious. So one example of which is your diazepam, which is just short acting. Then you have your antiemetic, okay, such as your promethazine. Then you have class your diuretics, okay, diuretics that would help reduce the fluids. So you have your hydrochlorothiazide, your triamterene, and then your spironolactone. Okay, intratympanic gentamicin is also given to the patient. This class usually is prescribed if the patient is non-compliant to the therapy or the medications. So what would gentamicin do? Your gentamicin would cause ablation. In other words, distraction of the vestibular nerve. And this is usually done, of course, under local anesthesia. Then you'll have the surgery. Okay, I'll discuss the surgeries on the next slide. Class, this is, by the way, an example of an audiogram which would show your Pike's peak, which I mentioned to be a characteristic of your Meniere's disease. Class, the main aim of surgery in Meniere's disease is to eliminate your vertigo. Elimination of vertigo only. Okay, because hearing loss, tinnitus, and oral fullness, okay, or aural fullness may still continue. Basically, the purpose of your surgery is to prevent the brain from receiving the input from the semicircular canals in such a way that the paroxysmal vertigo would stop. So what are these surgeries? You have your labyrinthectomy. Labyrinthectomy, as the term implies, labyrinthectomy, so that would include total removal of the labyrinth or resection of your vestibular nerve. Okay, now, you also have your endolymphatic sac decompression or shunting. The purpose of this is to equalize the pressure in the endolymphatic space by using a tube that is inserted to improve the fluid drainage. Again, we have your vestibular nerve sectioning. So, this provides the greatest success rate, approximately 98%, in eliminating the attack of vertigo. So, the nerve will be cut. That will prevent the brain, of course, from receiving input from the semicircular canals. But again, this would only address your vertigo, but not the hearing loss, which is more frustrating actually on the part of your patient. So that's it for your Meniere's disease. Now, you might be hearing of hearing aids and wondering what hearing aid is for. Now, when I talk about hearing aids class, it is actually a device with a microphone which is converted, okay, converts electrical signs, amplified, and reconverted to acoustic signals. Its goal is to make the sound louder, but it does not actually improve the patient's ability to discriminate words. Okay, your hearing aid has the capability to amplify sounds, but take note, it can also amplify your background noises. That's why it's still distracting to some patients. There are different types of your hearing aids. One, you have your completely in the canal. Two, you have the in the canal, which is used for mild to severe hearing loss. Then you have the in the ear. You also have behind the ear. Try to check on the advantages and disadvantages of which are discussed on your textbook. Well, caring for the hearing aid. So class, you need to wash the ear mold with a daily, that is using soap and water. Watch out for the following: whistling noise, pain, ulcer, redness, pain relating to the jaw area, and fever. Whenever these signs and symptoms are visible, your patient needs to go back to the ear doctor. Okay? So class, in that case, your ear doctor are referred to as your otolaryngologist. Okay, then you have your battery replacement. Try to review your textbook and find out how many hours, days, or months does it take for the battery of a hearing aid to be replaced. And then if you have noticed class, you need to move them far from objects which could possibly alter the signals, examples of which are your mobile phones, okay, which could affect the signal of your hearing aids. Now class, you also have what you refer to as your implanted hearing devices. There are actually three types right now. So you have your BAHA, bone-anchored hearing aid, which is used for conductive or mixed hearing loss, which is implanted behind your ear in the mastoid area. You have your MIE, okay, or your MEI, which is your middle ear implantation. Okay, as the term implies, it's implanted in the middle ear, that is used for sensory neural hearing loss. Then you have your cochlear implant for patients with profound hearing problems. Class, that will be the end of your discussion in your ear disorders. Congratulations for getting this far. Your next topic will be the musculoskeletal system and its accompanying disorders. Once again, continue to dream a little bigger. Thank you for your attention.